Good morning, everyone. Mm, I'm honored to join you here at the European Wellness Seminar. Mm, My name is Marta Dzhus from Bohemol's National Medical University, Kyiv. It is my second part of my speech, which is more practical, and I will speak about an often overlooked condition, sarcopenia. Specifically, its occurrence in inflammatory arthritis in younger population. As it is well known that sarcopenia is age-related, but now we recognize that chronic inflammation, reduced physical activity, and systemic disease can drive muscle loss in younger adults. This is especially true in chronic inflammatory arthritis. Unfortunately, secondary sarcopenia is rarely recognized until functional impairment has occurred. Today, I hope to raise awareness of secondary sarcopenia and demonstrate how timely intervention can reverse it. So, according to the definition, European Working Group on Sarcopenia in Older People defines sarcopenia around muscle strength rather than just mass. It's now diagnosed in 3 steps. First, low muscle strength is a probable sarcopenia, low muscle quality, confirmed sarcopenia, and low physical performance, severe sarcopenia. We distinguish primary sarcopenia, which is age-related, from secondary sarcopenia, which is associated with some diseases, immobility, or malnutrition. And this is the focus of today's talk. To quantify muscle mass, we use DEXA scanning to measure appendicular lean mass, ALM, the lean mass in arms and legs. We then calculate the ASMI by dividing ALM and by height squared. Diagnostic thresholds for men less than 7 kilograms per square meter, and for women less than 5.5. These values help confirm sarcopenia when paired with low strength. Let's examine axial spondyloarthritis. This chronic inflammatory disease affects the spine and sacroiliac joints. Persistent inflammation promotes muscle breakdown and impairs muscle building. Meanwhile, pain, stiffness, and fatigue reduce physical activity. The result is gradual, silent muscle decline, often unrecognized until it's functionally significant. Here is a real example. A 35-year-old male with a 10-year history of HLA-B27 positive axial spondyloarthritis presented with fatigue, weakness, and reduced activity. He could no longer climb stairs easily, rise from chairs, or grip objects well. Although his disease was treated with NSAIDs, physical inactivity was worsening. His posture showed classic ankylosing spondylitis related kyphosis. His activity disease score were high. BASDA was 5 out of 10, ASDAS 2.6, and muscle testing showed proximal weakness, especially in the lower limbs. His grip strength testing with dynamometer showed right hand 20 kilograms, left hand 18 kilograms. Both are well below 27 kilogram cutoff for men, confirming probable sarcopenia by European criteria for sarcopenia score. He performed DEXA. The DEXA scan showed lumbar spine T-score 1.2, femoral neck T-score minus 2.6, and z-scores similarly low. This suggests coexisting osteopenia, which is a common companion of sarcopenia in inflammatory disease. So sarcopenia is usually associated with osteopenia. ALMI was calculated at 6.8, which is below the 7 cutoff for men. With both low strength and low mass, this patient met the criteria for confirmed sarcopenia, and it is secondary to chronic inflammatory disease. So we implemented a multidisciplinary approach for his treatment. First of all, resistance training, 3 times a week, lower limbs and core focus. Protein intake, 1.2 grams per kilogram per day. Pain management, optimized NSAID regimen. And mainly biological therapy, we started adalimumab due to high disease activity. After 1 year follow-up, his grip strength increased to 28 kilograms on the right hand and 26 kilograms on the left. ALMI rose to 7 kilograms per meter square, and patient reported less fatigue and more autonomy. Sarcopenia was reversed, demonstrating that early targeted intervention works. So this case reminds us that sarcopenia can affect young adults, and it is often missed. Delay in the diagnosis lead to worsening disability and lost independence. We must integrate sarcopenia screening into routine rheumatology care. Resistance training is the cornerstone of treatment. It builds muscle mass, improves strength and function, and reduces fall risk. But without adequate protein and vitamin D and anti-inflammatory control, progress will be limited. We recommended routine grip strength testing in axial spondyloarthritis and juvenile arthritis patients and other patients with other inflammatory diseases. Screening when fatigue or weakness is present. Early rehab and nutritional support. Close collaboration among rheumatologists, physiotherapists, and dietitians. Let us move now to our second case. Here is a 22-year-old female with polyarticular juvenile idiopathic arthritis, which was diagnosed at the age of 7. Despite methotrexate, she had persistent disease activity, fatigue, and weakness. Juvenile idiopathic arthritis doesn't just affect joints. It disrupts peak bone mass acquisition, especially during adolescence. Chronic inflammation, glucocorticoid use, and inactivity combine to impair both bone and muscle development. At presentation, this patient has high disease activity. JADA's 27 score was 18. ESR was 35 and C-reactive protein 25. Her morning stiffness was rather long, more than 2 hours, and she has difficulty standing and climbing stairs. She was suspected muscle and bone loss. So she was performed DEXA, and DEXA showed a lumbar spine T-score minus 2.7, femoral neck T-score minus 1.4, ALMI 5.3, hand grip strength 14 on the one hand and 15 kilogram on another hand. All values below threshold, confirming secondary sarcopenia due to juvenile idiopathic arthritis. So we escalated the therapy. First of all, we prescribed etanercept as biological treatment to 50 milligrams weekly. Multimodal exercise, low impact aerobic resistance, balance, nutritional support, 1,000 milligram of calcium and 4,000 units of vitamin D. And program was joint sparing and tailored to head pain level. After 3 months, disease activity measured by JADAS-27 dropped to 8. Morning stiffness was less than 30 minutes. Synovitis decreased. Labs improved. Energy, mobility, and mood improved significantly. After 2 years, DEXA also improved. In the lumbar spine, T-score improved from minus 2.7 to minus 2.3. Femoral neck T-score improved to minus 1. Bone health improved as inflammation subsided and exercise increased. Muscle mass also improved. ALMI 5.9, hand grip on the right 18, on the left 16. She no longer met sarcopenia criteria. Clear proof that treatment reverses decline. Key takeaways. Juvenile idiopathic arthritis patients need proactive bone and muscle screening. Treat high disease activity aggressively. Biologics help both joint and musculoskeletal health. Exercise should be mandatory, not optional, in juvenile idiopathic arthritis. And in conclusion, sarcopenia in young adults with inflammatory arthritis is often overlooked. It is clinically significant and potentially reversible. Success requires inflammation control, mechanical stimulation via resistance exercise, adequate protein and vitamin D, and if we recognize it earlier and treat it earlier, the result will be better. So thank you for your attention. I'd be happy to take any question, and please feel free to connect with me at my email. Thank you.